This is Chapter 6 of the ATI Maternal Newborn Assessment of Fetal Well-Being. This chapter includes the assessments that determine the well-being of a fetus during pregnancy. Diagnostic procedures include ultrasound, biophysical profile, non-stress test, contraction stress test, and amniocentesis. Additional diagnostic procedures for high-risk pregnancy include percutaneous umbilical cord blood sampling, chronic villus sampling, quad marker screening, and maternal alpha fetal blood levels. Ultrasound. This is abdominal, transvaginal, and Doppler. Ultrasound is a procedure lasting approximately 20 minutes that consists of high-frequency sound waves used to visualize internal organs and tissues by producing a real-time, three-dimensional image of a developing fetus and maternal structures. An ultrasound allows for early diagnosis of complications, permits earlier interventions, and thereby decreases neonatal and maternal morbidity and mortality. There are three types of ultrasound: external abdominal, transvaginal, and Doppler. External abdominal ultrasound is a safe, non-invasive, painless procedure whereby an ultrasound transducer is moved over the client's abdomen to obtain an image. An abdominal ultrasound is more useful after a first trimester when the gravid uterus is larger. The client should have a full bladder for the procedure. Transvaginal ultrasound, an invasive procedure in which a probe is inserted vaginally to allow for a more accurate evaluation. An advantage of this procedure is that it does not require a full bladder. It is especially useful in clients who are obese and those in the first trimester to detect an ectopic pregnancy, identify abnormalities, and to establish gestational age. A transvaginal ultrasound can be used in the third trimester in conjunction with abdominal scanning to evaluate for preterm labor. Doppler ultrasound blood flow analysis, a non-invasive external ultrasound method to study the maternal fetal blood flow by measuring the velocity at which red blood cells travel in the uterine and fetal vessels, using a handheld ultrasound device that reflects sound waves from moving target. It is especially useful in waves from a moving target. It is especially useful in fetal intrauterine growth restriction and poor placental perfusion, and an adjunct in pregnancies at risk because of hypertension, diabetes, and multiple fetuses or preterm labor. Two-dimensional is a standard medical scan, black, white, or shades of gray. Three-dimensional is a multiple pictures at once, almost as clear as a photograph. Images look more lifelike than standard ultrasound images. 4D is like 3D but also shows fetal movements in a video. Indications: confirming pregnancy, confirming gestational age, identifying multi-fetal pregnancies, ruling out verifying fetal abnormalities, observing fetal movement, adjunct for other procedures. Vaginal bleeding evaluation, questionable fundal height measurements in relationship to gestational weeks, reports of decreased fetal movements, preterm labor, and questionable ruptures of membranes. Considerations: abdominal ultrasound. Explain the procedure and that it presents no known risk to self or fetus. Advise the client to have a full bladder during the ultrasound to lift and stabilize the uterus. Apply an ultrasonic transducer gel to the client's abdomen before the transducer is moved over the skin. Allow the client to empty their bladder at the termination of the procedure. Provide the client with a washcloth or tissues to wipe away the gel. Transvaginal ultrasound. Assist the client into a lithotomy position. The vaginal probe is covered with a protective device such as a condom, lubricated with a water-soluble gel, and inserted by the client or examiner. During the procedure, the position of the probe or tilt of the table can be changed to facilitate the complete view of the pelvis. Inform the client that they might feel pressure as the probe is moved. Fetal and maternal structures can be pointed out as the ultrasound procedure is performed. Biophysical profile. Biophysical profile uses a real-time ultrasound to visualize physical and physiological characteristics of the fetus and observe for fetal biophysical responses to stimuli. It combines FHR monitoring, which is a non-stress test, and fetal ultrasound. Indications: non-reactive non-stress test, suspected oleohydramnios or polyhydramnios, premature rupture of membranes, maternal infection, and intrauterine growth restriction. Interpretation of findings. BPP assesses fetal well-being by measuring 5 variables with a score of 2 for each normal finding and 0 for each abnormal finding for each variable. FHR, reactive is 2, non-reactive is 0. Fetal breathing movements. At least 1 episode of greater than 30 seconds duration and 30 minutes is 2, absence or less is 0. Gross body movements. At least 3 body or limb extensions with return of flexion in 30 minutes is 2, less than 3 episodes is 0. Fetal tone. At least 1 episode of extension with return to flexion is 2, and slow extension and flexion or lack of flexion is 0. Qualitative amniotic fluid volume. At least 1 pocket of fluid that measures at least 2 centimeters is 2, and pockets absent is 0. Total score findings, 8 to 10 is normal, 4 to 6 is abnormal. Non-stress test is the most widely used technique for antepartum evaluation of fetal well-being performed during the 3rd trimester. It is a non-invasive procedure that monitors response of the FHR to fetal movement. A Doppler transducer and a tocotransducer are attached externally to the client's abdomen to obtain tracing strips. The client pushes a button and attaches a monitor whenever they feel a fetal movement, which is then noted on the tracing. This allows a nurse to assess the FHR in relationship to the fetal movement. Disadvantages of the NST include high rate of false non-reactive results in the fetal movement response, blunted by sleep cycles of the fetus. Indications. Assessing for an intact fetal CNS during the 3rd trimester, ruling out the risk for fetal death in clients who have diabetes, used twice a week starting at weeks 28 to 32. Decreased fetal movement, intrauterine growth restriction, post-maturity, kidney disease, and multiple gestation. Client preparation. Seat the client in a reclining chair or place in a semi-Fowler or left lateral position. Apply conduction gel to the client's abdomen, apply 2 belts to the client's abdomen, and attach the ultrasound transducer and tocotransducer. The NST is interpreted as reactive to the FHR, accelerates at least 15 a minute for at least 15 seconds, and occurs 2 or more times during a 20-minute period. Non-reactive NST is a test that does not demonstrate at least 2 qualifying accelerations in a 20-minute window. If this is so, a further assessment such as contractions test or BPP is indicated. Contraction stress test. This is nipple stimulated contraction test. Consists of a client lightly brushing their palm across the nipple for 2 minutes, which causes the pituitary gland to release endogenous oxytocin and then stopping the nipple stimulation when the contraction begins. The same process is repeated after a 5-minute rest period. Analysis of the FHR response to contractions determines how the fetus will tolerate the stress of labor. A pattern of at least 3 contractions within a 10-minute time period with duration of 40 to 60 seconds each must be obtained to use for assessment data. Tachysystole of the uterus should be avoided by stimulating the nipple intermittently with the rest periods in between and avoiding by manual stimulation of both nipples unless stimulation of one nipple is unsuccessful. Oxytocin stimulated contraction test, also known as oxytocin challenge test, consists of the IV administration of oxytocin to induce uterine contractions. Contractions started with oxytocin can be difficult to stop and can lead to preterm labor. Contractions include placental previa, vasoprevia, preterm labor, multiple gestations, previous classic incision from cesarean birth, and reduced cervical competence. Indications: high-risk pregnancies, non-reactive stress test, decreased fetal movement, intrauterine growth restriction, diabetes. Obtain a document, a baseline of the FHR, fetal movement, and contractions for 10 to 20 minutes. Explain the procedure to the client and obtain informed consent. Initiate nipple stimulation unless the client is having nipple spontaneous contractions. Instruct the client to roll a nipple between their thumb and fingers or brush the palm across the nipple. The client should stop when a uterine contraction begins. Monitor and provide adequate rest periods for the client to avoid tachysystole of the uterus. Initiate IV oxytocin administration if nipple stimulation fails to elicit a sufficient uterine contraction pattern. If hyperstimulation of the uterus or preterm labor occurs, do the following: monitor for contractions, administer tocolytics, maintain bed rest, and observe the client for 30 minutes. Negative CST is a normal finding, indication of within a 10-minute period within at least 3 uterine contractions there are no late decelerations of FHR. Positive CST is an abnormal finding. It's indicated that with late decelerations with 50% or more of the contractions, this is suggestive of a uteroplacental insufficiency. Potential for preterm labor. Amniocentesis is the aspiration of amniotic fluid for analysis by insertion of a needle transabdominally into the client's uterus in an amniotic sac under direct ultrasound guidance, locating the placenta and determining the position of the fetus. It may be performed after 14 weeks of gestation. Alpha fetoprotein can be measured from the amniotic fluid between 15 and 20 weeks and can be used to assess for neural tube defects in the fetus or chromosomal disorders. Can be evaluated to follow up high level of AFP in maternal blood. Previous birth with chromosomal anomaly, a parent who is a carrier of chromosomal anomaly, AFP level for fetal abnormalities. Pre-procedure. Explain the procedure to the client and witness informed consent. Empty the bladder prior to the procedure to reduce the size and reduce the risk of inadvertent puncture. Monitor fetal heart rate. Administer immunoglobulin to the client if they are Rh negative. All right, interpretation of findings. Alpha fetoprotein. High levels is associated with neural tube defects such as encephaly, spina bifida, or omphoceal. High AFP levels also can present with normal multifetal pregnancies. Low levels is associated with chromosomal disorders such as Down syndrome or gestational trophoblastic disease. Fetal lung maturity. Tests for fetal lung maturity can be performed if gestation is less than 37 weeks. In the event of a rupture of membranes for preterm labor or for complication indicating a cesarean birth, amniotic fluid is tested to determine whether the fetal lungs are mature enough to adapt to extrauterine life, or if the fetus will likely have respiratory distress. Determination is made whether the fetus should be removed immediately or if the fetus requires more time in utero with the administration of glucocorticoids to promote fetal lung maturity. Complications. Amniotic fluid emboli, maternal or fetal hemorrhage, inadvertent material, intestinal or bladder damage, leakage of amniotic fluid. Nursing actions. Monitor vital signs, temperature, respiratory status, administer medications as prescribed. High-risk pregnancy, percutaneous umbilical blood sampling. Percutaneous umbilical blood sampling, commonly called chordocentesis, is the most common method used for fetal blood sampling and transfusion. This procedure obtains fetal blood from the umbilical cord by passing a fine-gauge fiber optic scope, which is a fetoscope, into the amniotic sac using the amniocentesis technique. The needle is advanced into the umbilical cord under ultrasound guidance, and blood is aspirated from the umbilical vein. Blood studies from the chordocentesis can consist of Klinefelter-Bedke test that ensures the fetal blood was obtained, CBC count with differential, indirect Combs test for Rh antibodies, karyotyping, and blood gases. This is indications is determining fetal blood type and anemia screenings. Administer medications as prescribed and monitor the FHR as prescribed following procedure. The interpretations of findings evaluate for isoimmune fetal hemolytic anemia, assess for need for fetal blood transfusion, and determine specific regarding genetic mutation. High-risk pregnancy, chronic villus sampling. Chronic villus sampling is an assessment of a portion of the developing placenta, which is aspirated through a thin sterile catheter or syringe inserted through an abdominal wall or intravaginally through the cervix under ultrasound guidance. CVS is a first trimester alternative to amniocentesis, with one of the advantages being an earlier diagnosis of any abnormalities. CVS is ideally performed at 10 to 13 weeks of gestation. The advantage of an earlier diagnosis should be weighed against the increased risk of fetal anomalies and death. Indications is risk for giving birth to a neonate who has genetic chromosomal abnormalities. The complications are spontaneous abortion, risk for fetal limb loss, miscarriage, and chorioamniotis and rupture of membranes. High-risk pregnancy quad marker screening. This is a blood test that ascertains information about the likelihood of fetal birth defects. It does not diagnose the actual defect. It can be performed instead of a maternal AFP blood level yielding more reliable findings. Includes testing for human chronic gonadotropin, a hormone produced by the placenta, alpha fetoprotein, a protein produced by the fetus, estradiol is a protein produced by the fetus and placenta, and inhibin A, which is a protein produced by the ovaries and placenta. Indications: preferred at least at 15 to 22 weeks gestation, and its risk for giving birth to a neonate who has a genetic chromosome abnormality. High-risk pregnancy, maternal alpha fetoprotein. This is a screening tool used to detect neural tube defects. Clients who have abnormal findings should be referred to a quad marker screening, genetic counseling, ultrasound, and an amniocentesis. All pregnant clients, preferably between 16 and 28, are diagnosed.